So today we'll be discussing about community-acquired pneumonia. So what is pneumonia? Pneumonia is inflammation of the lung. We know that pneumonia is the leading cause of death in a children below 5 years of age. In 2010, there are 210 million cases of pneumonia worldwide, and in 2011, 1.3 million deaths occurred due to pneumonia. So you can understand the severity of this condition. The pneumonia can be various types like community-acquired pneumonia, hospital-acquired pneumonia, or ventilator-associated pneumonia. So we have already discussed about hospital-acquired pneumonia and community-acquired pneumonia previously. The link is given above. So now we will discuss about community-acquired pneumonia. So before we start, let's first understand what are the common organisms causing pneumonia. Two major causes of pneumonia are Streptococcus pneumoniae this is the most common, and Haemophilus influenzae. Both these organisms are common between 3 weeks to 4 years of age. And in 5 years and older children, the common organisms are Mycoplasma pneumoniae and Chlamydia pneumoniae. Then some rare causes of pneumonia are Legionella, Staphylococcus, aureus, and gram-negative organisms like Pseudomonas, Klebsiella, etc. So basically these organisms are more common in ICU setup. Then some viruses may also cause pneumonia, like commonly H1N1 virus. And in 40% of the cases, no etiology can be found in case of pneumonia, and it is seen that out of those, almost 20% cases are due to Mycobacterium tuberculosis. So tuberculosis is another very important cause of pneumonia, but we will not discuss tuberculosis in this lecture. So as you can see, the etiology of community-acquired pneumonia can be divided into two types on the basis of organisms which can be prevented by vaccine and organisms which cannot be prevented by vaccines. So the organisms commonly implicated which can be prevented by vaccines are Streptococcus pneumoniae, influenza virus, Haemophilus influenza type B. And not preventable by vaccines are respiratory syncytial virus, which is an important cause of bronchiolitis, Staphylococcus aureus, which causes pneumatocysts, non-typhoidal salmonella, especially common in Africa, Klebsiella pneumoniae in malnourished children, Mycoplasma pneumoniae in more than 40% of the cases, very common if above 5 years of age and in adolescent age group. Chlamydia pneumoniae, more than 3 years, common. Mycobacterium tuberculosis, very important. Then parainfluenza virus 1 to 3, adenovirus, then coronavirus and Boca virus. So if we talk about vaccines, the Streptococcus pneumoniae can be prevented by pneumococcal conjugate vaccine. There are two types of conjugate vaccine, one is PCV10 and another is PCV13. So two type, PCV10 and PCV13. So pneumococcal conjugate vaccine PCV can be given starting from 6 weeks of age. The primary immunization, there are 3 doses at 6 week, 10 week and 14 weeks. and booster is given at between 12 to 15 months of age. So very important, PCV vaccine is very important. If this video is seen by some parents, so you should know that Streptococcus pneumoniae is the commonest cause of pneumonia in children, and pneumonia is the leading cause of mortality in below 5 years of child. So you can understand what is the importance of pneumococcal vaccines, and it should be given to each and every children. In Western countries, due to regular vaccination, regular immunization, pneumococcal vaccines, the mortality due to pneumococcal vaccine has reduced considerably. So if we talk about influenza virus vaccine is available as trivalent inactivated vaccine, which is also commonly called as swine flu vaccine or flu vaccine. So this vaccine can be given as early as 6 months of age, and for the first dose we have to give 2 doses 1 month apart, and if the child is above 9 years of age, then only single dose is required for the primary dose, and after that we have to do revaccination every year. And ideally the vaccine should be given as the vaccine is new vaccine is available in the market, you should give the vaccine, or this is before starting of the rainy season. So this influenza vaccine can be started from 6 months onward. First dose 2 doses first time before giving 1 month apart, and then annually, and it should be given when a new vaccine is available in market or just before rainy season. And finally, if we talk about Haemophilus influenza, also conjugated vaccine is available. It can be given as 6 weeks of age, so it can be started from 6 weeks of age. Haemophilus influenzae primary series consists of 3 doses at 6, 10 and 14 weeks, and with a booster at 2 18 months. Now let us see the pathogenesis. So you can see in this diagram I have shown an alveoli. So this is the alveoli and this is the capillary. So gaseous exchange took place through this space. Okay, I have already mentioned the common organisms that causes pneumonia are usually present in the oropharynx. So the organisms are present in the oropharynx if due to any reason get aspirated a small amount, our body due to the defense mechanism will try to expel it out, like by cough reflex or mucociliary clearance or pulmonary macrophages will prevent it from getting infection. But if this defense mechanism is weak, then there may be inflammation. The defense mechanism is in fault. So what will happen? The pulmonary macrophages will try to kill the organism by cell mediated immunity. As a result, there will be inflammation and release of mediators like interleukin 1, interleukin 8, TNF alpha, etc. Due to this inflammation, there will be exudation from the capillary membrane to the alveoli. So as a result, the alveoli will be full of exudates. So exudation, and ultimately there will be formation of consolidation. So due to this consolidation, there will be impairment of oxygenation via the capillary membrane. As a result, there will be hypoxia. So when there is hypoxia, the child will show features of hypoxia in the form of cyanosis. There will be big difficulty in breathing. There will be maybe work of breathing may be increased. The accessory muscles of respiration will come into act, like nasal flaring, subcostal retraction, and all these features. So in a children, typical features of lobar pneumonia are not present. So there may be refusal of feeding, signs of toxicity, or subcortical. So now we will discuss about the pathology of lobar pneumonia. So lobar pneumonia is the most common type of pneumonia. That was why we will be discussing about lobar pneumonia, but it's not the end. There are this is lobar pneumonia is a typical pneumonia, and there is another type of pneumonia which is called as atypical pneumonia. We'll come to that. First of all, let's see the pathology of lobar pneumonia. In lobar pneumonia, there are in lobar pneumonia there are four phases. The first phase is known as phase of congestion. Second phase is known as phase of red hepatization. You can see in this diagram. So this is second red hepatization, is gray hepatization, and fourth is resolution. So the phase of congestion lasts for first 1 to 2 days. Red hepatization from 3 to 4 days. Gray hepatization 5 to 7 days, and resolution occur between 7 to 8 days. So initially during congestion, there is acute hyperemia and edema with bacteria and proteinaceous. After that, there is neutrophilic exudation. So neutrophils, febrile congestion, and in the third stage, there is degradation of the red blood cells, and there is fibrosuppurative exudative, fibropurulent exudative. And during the resolution phase, macrophages comes into action, which causes healing of the lung parenchyma. So this lobar pneumonia is commonly seen with Streptococcus pneumoniae, Haemophilus influenzae, and sometimes with Staphylococcus aureus, then your Klebsiella or Pseudomonas, but most commonly with pneumococcal. That means your Streptococcus pneumoniae and Haemophilus influenzae, and rarely with Staph aureus, Klebsiella, and Pseudomonas. So these are the common causes of lobar pneumonia. Then the question comes, what is atypical pneumonia? So what happened with Mycoplasma pneumoniae, Chlamydia pneumoniae? What happens with the viruses? So these organisms, viruses, Mycoplasma, Chlamydia, that doesn't causes this typical lobular consolidation. So in atypical pneumonia, which is mainly caused by the viruses and Mycoplasma and Chlamydia, especially in school-going children and adolescents, there is patchy consolidations or patchy involvement of the lung all over the lung. There is not a particular lobe is not involved, like in case of lobar pneumonia. So what happened in this condition? The child is having cough, like dry cough, mild fever, etc. But the symptoms will be less in comparison to the radiological sign. The radiological signs will be very severe, like patchy consolidation all over the lung. But the clinical features may not be that much severe. That is why also Mycoplasma and Chlamydia pneumoniae are sometimes called as walking pneumonia. That means the child is coming to the OPD walking. The symptoms are not so severe, but if you do a X-ray and there is severe patchy consolidation all over the lung, so that is the difference between the typical and atypical. In the typical pneumonia, this onset is acute, abrupt onset with rapid progression, severity. When in atypical pneumonia, there may be insidious onset, slowly progressing, long duration of cough, there may be dry cough, and there may be some other extra pulmonary symptoms like joint symptoms, skin rashes, etc. Now let us see some examples. So look at this X-ray. So this is the X-ray of a 14 years old boy with cough and fever. So what is seen in this X-ray? So what is seen in this X-ray? We can see that there is a opacity in the lower part of the lung, and it is involving a complete lobe. In the lateral view also you can see that a complete lobe is involved. Okay, so in this case the right lower lobe is involved. So this is a typical lobar pneumonia due to Streptococcus pneumoniae. Okay, now let us see another example. This is a 6-month-old child with history of fever and tachypnea. In the first X-ray, we can see there is hyperlucency. There is hyperlucency and hyperinflation. 1, 2, 3, 4, 5, 6, 7, 8, 9. So almost 9 intercostal spaces are visible, and there is hyperlucency. So what may be the diagnosis? Yes, it's a viral infection, most commonly due to respiratory syncytial virus. Same child, after 2 days you can see there is formation of patchy consolidation all over the lung. The clinical features of pneumonia depends upon the causative organisms, the age of the child. If it's a atypical pneumonia, then the symptoms are different. If it's a typical pneumonia, the symptoms are different, and it depends upon the age of the child. If it's an infant, then symptoms are different. If it's between a toddler, the symptoms are different. Or for a school going and adolescent, the symptoms are similar to that of the adults. So if you see the clinical features, so usually the findings are fever, cough, and sometimes sputum production. This is common symptoms in school going children. There will be increase in the respiratory rate, work of breathing will be increased, accessory muscles of respiration will be used, so there may be nasal flaring, subcostal traction, etc. And for infants, the symptoms, infant and preschoolers, we can classify according to the WHO. If we consider no pneumonia, if only cough and cold is there, we consider to be pneumonia if there is fast bleeding, that is more than 50 per minute for 2 months to 1 year, more than 40 per minute 1 to 5 years, and more than 20 per minute more than 5 years, and there is associated chest syndrome. And very severe pneumonia or severe pneumonia is said to be if there is any danger site along with the above points like not able to drink, feed, persistent vomiting, convulsions, cyanosis, lethargy, unconsciousness, stridor in calm baby, and severe malnutrition. And the treatment of community-acquired pneumonia will depend upon the clinical features, age group of the child, sign and symptoms, what is the common organisms we are expecting, what is the culture sensitivity reports. All these factors will have an impact on the treatment of community-acquired pneumonia in children. So before I simplify this whole protocol of community-acquired pneumonia, first let me take you to the Nelson textbook of pediatric so that you have a perception how Nelson is talking about the antibiotic protocol. Then I will give my simpler version of that, which we can commonly use in our day-to-day practice. So we will mainly discuss about the antibiotic protocol. So according to Nelson, if the pathogen is Streptococcus pneumoniae and the minimum inhibitory concentration is less than equal to 2 microgram per ml, then the preferred antibiotic is ampicillin or penicillin. Understand? Alternatively, we can go for ceftriaxone, or we can also go for clindamycin and vancomycin. The first is ampicillin and penicillin. But if we are considering oral parent therapy, that means the condition of the child is not so sick, not so severe, then we can give the child oral medicine. Then we should prefer amoxicillin, plain amoxicillin. Alternatively, we can give second or third generation cephalosporin like cefodoxime, cefixime, cefprozil, or oral levofloxacin or oral linezolid. If there is Mycoplasma pneumoniae or Chlamydia trachomatis or Chlamydia pneumoniae, then we should go for azithromycin. Oral also azithromycin is preferred. Okay, intravenous azithromycin or erythromycin or azithromycin orally, clarithromycin orally or erythromycin orally, or you can also go for doxycycline, levofloxacin and moxifloxacin. So this is the basic idea according to the Nelson. So Nelson is mainly focusing on the causative organism, the susceptibility. So practically very difficult to follow all these guidelines. So now I will discuss about the practical approach. What should be the practical approach in our day-to-day practice? As you can see, the first line draft for an ambulatory patient, that patient is an OPD patient, less than 5 years. So OPD patient less than 5 years, which can go for amoxicillin 40 to 50 milligram per kg per day orally twice daily for 5 days. Alternatively, we can give cefodoxime 10 mg per kg per day BID for 5 days, or cephalexin 75 to 100 milligram per kg per day thrice daily for 5 days. But if you are suspecting a atypical organism, atypical microorganism, like if there is a history of prolonged illness, prolonged cough, symptoms are not so severe in a post more than 5 years old or an adolescent, then you should add a azithromycin 10 mg per kg on the first day and then 5 mg per kg per day every day once daily for 5 days. Now if the child is non-ambulatory or required hospitalization, then we have the following recommendation. Treatment recommendation for hospitalized patient. The antibiotic should be given for 7 to 10 days. First line, always start with ampicillin plus minus gentamicin. Ampicillin plus minus gentamicin. So it will act against common organisms like Streptococcus pneumoniae. Okay. Alternatively, you can give penicillin plus minus gentamicin. Okay. Second line, if you are suspecting that there is some resistance organisms are there, then you can, as a first line, you should start amoxicillin clavulanic acid plus gentamicin. So if the child is a little bit sick and you are in a place where you are expecting that there is maybe some resistance organism, the child is already getting some oral antibiotic and not responding, in that case you can directly start the amoxicillin and clavulanic acid along with gentamicin. Okay, gentamicin will cover if there is any gram-negative organisms like Klebsiella, okay, if the child is sick, so that will help. Alternatively, you can start ceftriaxone, cefotaxime along with gentamicin. So this is an alternative. So either you go for amoxicillin plus gentamicin, or you go for ceftriaxone or cefotaxime plus gentamicin as a first line. Then if you suspect Staphylococcus aureus, in the X-ray there is pneumococcal is there. There are some skin infections were there apparently. So definitely in a child with there is a history of measles. So in a child with history of measles, then skin infection, then pneumonia, you should think about Staphylococcus. In that case, you can go for cloxacillin or vancomycin or clindamycin or linezolid. Similarly, alternatively also, maybe vancomycin or clindamycin or linezolid or cloxacillin you can add. So basically this is the antibiotic therapy in a community acute pneumonia.